Hello, everybody. In this part of our symposium, we have a guest from UK, Dr. Kostas Karagiannopoulos. Dr. Karagiannopoulos is a specialist and consultant prosthodontist and works in a specialist practice in London. He is a key opinion leader for GC UK, and he is an honorary consultant at King's College London, where he has been teaching and training the specialists and dental students since 2008. His main areas of interest are additive restorations and natural-looking prosthesis. The topic of his lecture today is composite injection molding. So welcome, Dr. Karagiannopoulos. We are happy to have you with us in our symposium.
Excellent. Thank you for having me, Sir Hat. Thank you for the invite. It's a pleasure to join you. I'm quite passionate about this subject, and I just wanted to share my experience on these injectable composites. So I'll just say a few things about myself. You guys will not know me. I'm from Greece, Athena originally, and I've lived in the UK for 26 years now. So I did all my training in London. That's where I am now. And I'm a prosthodontist, so I mainly replace missing teeth, but I do love composites a lot. I also teach in the local university, that's King's College London, and I do that 1 day a week, and for about 12 years now. So I'm between specialist practice and a university setting. So I have a little bit of both for real patients as well as the academic world. I love Turkey. I love Istanbul. I married a Turk. For a Greek, that is quite strange, but I did that crazy thing. And I wish I can come and see Istanbul again, because with COVID, it's not so easy now. But soon, I hope I'll come and visit Istanbul again. So I'm going to make a start. I'm going to go to maximum screen. So is that visible now?
Exactly.
Yes, is that okay?
It is visible. Exactly.
So, injectable composites. Now, why even talk about this? Why not just do freehand composites? So I'm going to be talking about injectable versus freehand. Freehand means all the composites everyone is doing. We just shape them, we sculpt them, and they're great. They're always going to be needed. But this is just a different technique. So instead of giving you some boring aims and objectives, I'm just going to show you 6 pictures of what I'm going to be talking about. I'll be talking about diagnosing the problem, finding out where the teeth need to be, which as a restorative dentist, it's our job every day. Then how to order a wax up from the lab, and then try this out in the mouth. If it's an additive wax up, you can do a mock-up just to see how things will end up. And then when the mock-up is looking good and we approve it, then we can go ahead and do injectable composites, wax up driven composites, predetermined composites, and complete the case. So that is the workflow that I will discuss. And I have here a 1-minute video of that workflow just to get the dynamics of the technique. that was just a brief video, brief summary of the whole kind of process. It is a fairly recent technique. It's been available for quite a few years, and we can use this technique because the materials have evolved a lot. So flowable composites, they are not weak anymore. They have changed a lot. So I'll go into the material science, and I know that Serhat has worked on that during his PhD. But let me go first on why do it? Like, what is it helping us with? Why cannot do freehand all the time? So in the university where I work, we do see a lot of tooth wear cases, erosive or bruxism, it doesn't really matter. So the teeth are getting smaller, and to get the palatal shape correct based on a wax up, this is very difficult to do with freehand. It takes a lot of time, and it's difficult to be consistent. So tooth wear cases where we're adding on 4 teeth or 6 teeth, or maybe the whole arch, the injection molding is very helpful. It's speeding up the process, and it's making it consistent. Diastemas is a great indication. Another way to do it is use some BioClear matrices, which are very curved, and it's type of an injection molding. Another indication is the makeover patient, the aesthetically driven patient. There is a stereotype here in the UK that, hey, if you want to do your whole teeth, you go to Turkey, you go to Antalya, or I don't know where, and you have a Turkish holiday and you do your teeth. So these cases are great for injection molding because you do a wax up like you go for porcelain, but just before you go for porcelain, you actually use resin. So this is a perfect indication. A last indication is when you're making some occlusal changes and you are building up some teeth and maybe make a denture around these teeth all on the same day. The injection molding technique is very helpful. What is it not helpful for? Black triangles. So getting in between the teeth where the gum has receded, that doesn't really work with this technique. If you have a single tooth and you want to do lots of effects and opalescence and halos and all the things that Serhat is doing beautifully, this technique is not the right technique. It's not designed for layering. It's designed for one shade. You can use a bit of layering, but it's not designed for that. If you have a trauma and a kid comes to you and they broke a tooth, this technique, again, is not very helpful because it takes several appointments. You have to do your diagnosis first, you have to do your mock-up, you have to do the final bonding, and that takes quite a few weeks. And people, they just want their teeth fixed. So trauma, you got to use layering. If you're making very small additions, again, freehand is better. So let's think of how we design our porcelain veneers and crowns. Do we just freehand them? No. We order a wax up. We tell the lab, hey, please add on the buccal, please add on the incisor, and all the things that we do in a smile design. And then we get a stent, a putty matrix from this. In this case, it's a putty and wash made in the lab, and that will be used as our prep guide and our temp guide. Imagine if you have a big case of 10 porcelain veneers, the patient is on the chair, but the lab work hasn't arrived. It's happened to me, it's happened to you. And the look on my face is like this. Where is my stent? Where is the guides? I cannot work without them. How am I going to make temporaries freehand? I can do it. I don't want to do it. Let's talk about alternatives. So freehand is the king or the queen. And injectable is just a supplementary technique. It's just an extra technique. So freehand can be universal, A1, B1, B2, whatever, or layered, which means your dentin and enamels. So half the composites these days are vita-based, half are anatomically based. In the north of Italy, Federico Ferraris and Riccardo Amanato described the index technique. It's a beautiful technique where you have a clear silicone stent, but for each individual tooth. And if you're adding on a quadrant, 4, 5, 6, and 7, you just use your small stents per tooth. It's a technique that's designed to have easier cleanup. That's why you do individual teeth. And they have described that very, very well. One of my mentors in composites, Didier Dischi from Geneva, has described partial and full molding techniques. He has an excellent program on the worn dentition, and most of the things that I've learned about composites, I've learned them from him. A simpler way of what I'm describing is the stamp technique. You have a tooth with some caries, you know it's going to be a big cavity, but the occlusal anatomy is there. So you take a little index with some block-out resin or flowable composite or whatever, and then you copy, paste. The last alternative to injectable composites is, of course, the world of ceramics, which will always be used and has its advantages. Now, why do the injectable technique? Because you copy the anatomy. You have a wax-up, and the wax-up is made from a dental technician. Some of you may have the skills of Didier Dischi. I don't. But my lab technician can give me an excellent wax-up, which I copy-paste. The technique is easy. It's also easy to teach. I teach that technique for GC here in the UK, but you need some hands-on training. It's not something that you can just buy a little bit of clear silicone, an injectable composite, and do it tomorrow morning. You need a hands-on course. You have the ability to check aesthetics, occlusion, and phonetics. And we all have patients that we have done cosmetic work for. We told them, hey, I'm going to give you this. But then the patient says, no, you didn't give me this. I don't like it. You have to start again. So this technique avoids misunderstandings. Why? Because you do a mock-up. And on the mock-up, you filter all the problems. It's a very predictable workflow, but it has these 3 steps: diagnosis, mock-up, inject. Disadvantages. Compared to freehand composites, where you do everything there and then, it's more expensive. You have to order a wax-up, you have to order a stent, and these things cost money. Also, they cost time, because you need to bring the patients back. It's also designed for monochromatic rather than layered. You need an excellent lab support. Since I've been doing injectable composites, the relationship with my lab has improved massively. So we speak all the time. The mock-up is very useful test drive, but it's not a free test drive. Otherwise, if we don't get paid for something, we're not going to enjoy it. So doing the mock-up adds a little bit to the cost of treatment. So why should we use the labs to help us? 2 reasons. It saves time, and it gives us the right anatomy. This is a statue of Ronaldo in his birthplace in Madeira, which doesn't look very good. So some of my composites look like that. But if my lab makes the wax up, it doesn't look like that. Now, some of you are going to be working 100% on the digital workflow, which is great, because it means that your lab works with you on the digital workflow. Some of you will use alginate and stone models and conventional wax-ups. So let's talk about the two techniques. Analog involves taking a bit of wax and shaping it on the stone models. It's been done for, I don't know, 60 years, 70 years. It's excellent at anatomy. I think it's better than the digital anatomy. We have lots of tooth libraries, like the anteriors from Jan Hayito. They're excellent, but I still find that a handcrafted wax-up is more beautiful in terms of anatomy. It's more difficult to get symmetry on the analog, whereas you can do a mirror image for the digital, and one central incisor, you can copy it on the other. Gypsum models are going to have porosities, and that creates problems for the stents sometimes. So gypsum is not perfect because of the porosities. That's why you need to put the model in water for 5 minutes, so that when you make a stent out of that, it's easy to remove. The digital has its own problems. Some printing resins will interact with a clear silicone and they will attack each other. Doesn't happen a lot, but it is a problem. Another problem is that the clear silicone, it's called Exaclear from GC, it has so much detail that it will actually pick up the printing lines on the teeth, which look like circles, like a heat map on the printed model. And then I will have this on my composite. I don't want this on my composite. A big advantage of the digital workflow is that you're going to get everything quick. You don't rely on the courier, on post. You email your Trios or your Prime Scan, whatever, and the lab can do it very quickly. The cost is not cheaper. So many people think that the digital wax-up is going to be cheaper because it's all done on a software. Well, it's not. They charge the same. Sometimes they charge more, actually. Now, requirements for an excellent wax-up. This injection molding technique relies on an excellent wax-up and an excellent stent. The material that we're going to be talking about is called Universal Injectable from GC, and that is an excellent material too. But it will only work if the wax-up is beautiful. So you need great diagnostic records. I've taken many alginate impressions in 20 years with lots of bubbles and drags. They're not going to work. If you take a scan, you don't really have the opportunity to make a mistake. So that's an advantage for the digital. You need a full set of photographs and some sort of a way to relate the occlusal plane and the incisal plane. A face bow is one of them. I ask my lab to make the wax on a different color than the model because I want to see where I am adding. It's important for me to know when I'm injecting. If it's the same color, I do not know how much they have added and where they have added. You need excellent detail. So you can see in the background, oopsie. You can see in the background that there is very good detail on the cervical margin because the emergence profile is a problem for restorative dentistry. We all made temporary crowns or composites where the emergence profile is wrong. So the detail has to be fantastic from the lab, especially interproximally, between the teeth, because that's where the clear silicone will go, to stop the composites sticking to each other. I also ask the lab to finish the wax about 1 millimeter from the gingival margin. That acts as a stop, so that the clear silicone stent stops on the teeth cervically. Ways to improve the lab communication include the full set of photographs. I'm not going to talk about the full set of photographs because we're going to be here forever. Mounted models will help, but maybe a stick bite or just the conventional pictures with retractors are good to help the lab work out an incisal plane. Let me go through what I ask my labs when I'm prescribing a wax-up. This has nothing to do with injectable composites. This is the same for ceramics, exactly the same. First, is this a wax-up going to be additive or subtractive? If you only add, you can do a mock-up. If you subtract, you cannot do a mock-up unless you touch the teeth first. About 10 years ago, I came to Nishantasi to listen to Galip Gürel, who taught the whole world his technique of APTs and blah, blah, blah. So you are probably very much aware of what I'm talking about more than other countries. The second thing I'm telling my lab is, do I change the occlusion or not? In this case, I changed the occlusion. The teeth were very worn. I opened up the vertical dimension and the lab waxed up the anterior teeth. The back teeth were kept apart. This is a concept called a DAL concept. We use it a lot in North Europe, and it's an orthodontic idea. The other thing I'm going to tell the lab is, how's the midline? Is the midline correct? And how is the incisal plane? I will send them photos, but I will also tell them that, hey, we have a cant. That needs to be fixed. Number 4 on my lab script, prescription, will be, am I adding length? Usually, when somebody's having cosmetic treatment, we're going to be adding length. It's very rare that we're going to be subtracting length. Are we adding facial volume? Very common. Widen the smile. Many people do not want orthodontics. They want restorative orthodontics. So we're adding on the facial volume, maybe 1 millimeter, maybe 2, to widen the smile, to give them a fuller smile. The next thing I'm going to be telling them is the teeth to be restored. And something, again, that I learned from Galip Gürel and Visagesian about the incisal silhouette. On the bottom left picture, I did a mock-up for this young girl based on her anatomy, based on how her teeth normally are. She did not like it. She told me, I'm paying all this money. I want to look different. I don't want to look like myself. I was shocked. She wanted very square, no incisal embrasures. I did not like that look, but I gave it to her. She's the customer. The last thing I'm going to be asking the lab is what stents I want. This is a clear silicone stent made from the wax-up. This is a small example. Tooth wear with variable edges, a small smile design. If you want to use software like DSD, it's great. I just use a technique that I learned from Spear Education in America of just drawing some lines myself on my iPad. So I just take my pencil and I just design where the teeth need to be. I send this to the lab and I tell them, hey, make me a wax-up like this. And this is the digital version of the pre-op, and this is the digital wax-up. And they will then print a model, and from that we can make a patty guides. Let's talk about mock-ups. The idea of a mock-up has revolutionized restorative dentistry. This Gurel technique is a technique that everyone is teaching. They're just calling it different names. The main material to do a mock-up is bisacryl. It's cheap, it's easy, and in the last 20 years, it's taken over PMMA. If you want to use flowable composite, you can, but it's an expensive mock-up. So this material on the left is my preferred material, is an excellent material from GC, which is highly filled. Sometimes I do a mock-up with this if I'm not sure about the shade. So I will actually use A1 or B1 or whatever, because the bisacryl A1 is not always the same as composite A1. The classic materials for provisionals or mock-ups has been polymethyl methacrylate. In the modern era, printed or milled, or the good old-fashioned powder and liquid. This is from Michel Magne in California. Now let's talk about clear silicones. There's lots in the market, and I have used all of them. Only one is clear, and you can see which one that is. So at King's College, where I teach, it's a huge hospital, we use Memosil from Heraus. It's fantastic, it's very rigid, but it's blue. The Zermac product is cloudy, and I cannot see through it. If I'm going to be injecting through a clear silicone, I need to be able to see through it. I need to know what's going on underneath. We're dentists, we're control freaks. You know what I mean. This is a different ways to make these stents. So on the top right, you can see a clear silicone stent made on a model. What I need as a restorative dentist is I need the distance between the incisor ledge and the end of the silicone to be the same on all the teeth. It should be about 5-6 millimeters. So if this clear silicone is not squeezed with something, it's going to be uneven. I started doing this with what GC recommend, which is a metal tray. I do not like this technique anymore because the clear silicone might be short in some areas and long in others. Then I moved on to a printed a tray, like the one on the middle of the screen, but that was leaving printing lines on the Exaclear, so I stopped that. So now I've used a modified Essex retainer. I make a patty stent over the wax up, and then I blow an Essex retainer on top. It's perfectly clear, and it's going to compress the Exaclear. These are things that if you go on a hands-on course, you will learn more and practice. This is how the Exaclear stent looks. So we have these tips, which are going through the clear silicone into the tooth. Here I'm using the alternate tooth technique, where I'm injecting on the 3, the 1, and the 2. And this is how I insert it in the mouth. The GC tips are very thin and they're very long, so they're perfect for this technique. I will sit this down in the mouth, and I will just use the syringe first on the canine, then I will move the syringe on the central incisor, and then move the syringe on the lateral incisor. The tips stay there at all the time. Let's talk about materials. You may all think that, hey, they're weak. I'm not going to take flowable composite and put it on the incisor ledge of my Braxist patient. You must be mad. Well, the filler content has gone up a lot. The higher the filler content, the less the life and the aesthetics of the composite. It's going to be less translucent, less polishable. It's not going to have so much depth. These are 4 materials which are very popular in terms of their flowables. And these are the filler content per weight. The one from Curaray is 75%, one from GC is 69%. You can see the numbers. The Ivoclar one is super beautiful. It's amazing, but it's a weaker material. I believe the GC one at 69% has a very good balance. This is from GC Research and Development, and they're very proud of the flexural strength. What I can tell you is that the flexural strength of this injectable composite is the same or higher than that of composite pastes. And some of the composite pastes you're already using are weaker than the injectable composites, which might sound ridiculous, but it's true. There's not a lot of evidence on these materials. There's some in vitro studies, not a lot of clinical studies. It's a new concept. The material has only been out from 2019, and COVID struck, so nothing was really happening in big universities. This is an in vitro study out of Japan, where they're comparing several flowable materials. Gracefield flow is the name of how they call it over there. They have just a different name. And high flexural strength, very good physical properties, very good wear resistance also. Yes, these are all in vitro studies. The handling properties and the thread formation are very good. This is how much force you have to put in order to inject that. So the outcome of this lab study was that it can be used in high stress bearing areas, but it's lacking the clinical data. Other applications of flowable composites have been used in kind of posterior areas and successfully, but not exactly for what we are describing. Class 2 restorations have been receiving highly filled composites, and again, it's an indication that they are comparable. It's not solid evidence. Another study from Turkey looked at class 5 cervical areas, non-Kerry cervical lesions, with promising data. I asked Serhat some time ago, and he kind of told me about his work. This, before I talk about Serhat's bit, this is a systematic review, again, for class 5 restorations of very good marginal adaptation and similar marginal discoloration. But the quality is doubtful. It's still early. So in terms of clinical follow-ups, this is one that maybe Serhat can tell us his opinion, that yes, excellent results after a year, but we need longer results. I'm actually starting my own prospective study at King's College, because we're using this injectable technique in a university setting now, and I want to monitor these after a year, but we need about 50 or 100 cases minimum. This is again provided by GC, and I don't want to bore you now, but on the left side, we have the old-fashioned genial anterior and posterior, and comparing the newer flowable versions. Your attention can go to the flexural strength. So the posterior old composites, the strong stuff, has a smaller flexural strength than the modern flowable composites. Okay, it has a higher filler content, and it actually has a smaller shrinkage, but the shrinkage is only at 3.5%. Very comparable. Let's go and look at some clinical cases. I'm not going to start with a fancy, like, cosmetic top teeth. I'm going to go on the bottom teeth. I'm going to go on the difficult ones first. So this is moderate wear. What I have done here is I have done some orthodontics. I have pushed the incisors down to create space for my composite. When you have worn teeth, they're going to be touching each other. And as Frank Spear always says, worn teeth in occlusion are in the wrong position. So I had to create space. I moved the teeth. I ordered the wax up. The wax up, as you can see, is not just on the incisal. I try to run this on the facial for a few reasons. First of all, it's going to look better. Secondly, it's going to block the line between tooth and composite. And third, you're adding significant amount of surface area of enamel for bonding. So most times you think there's no room to add onto the facial. Well, the mock-up usually proves you wrong, that things look okay, provided you don't overdo it. You just add 0.5 millimeter of volume, which is again the idea of additive mocking up before you subtract for ceramics. Exactly the same. This is the incisal view. Just note the good detail on the proximal, because this is where the clear silicone will go and stop the composites from going everywhere. So the detail has to be fantastic. This is the clear silicone being made. Okay, it's a different case, but it doesn't matter. And this is the occlusal view. That clear stent has to be thick buccally, incisally, and palatally. How much? About 6 to 7 millimeters. It has to be uniform. You do a mock-up, you verify your aesthetics, you show to the patient, and the patient says yes. If they don't like it, then you go back to the wax-up and you find out what is wrong with it and you change it. After that, you create some vents. How do I make the vents? You can either cut one with a burr, diamond, tungsten, it doesn't matter. What I don't like about this is that it creates a lot of dust. I forgot his name now. The person who came up with Terry Douglas, that's it. The person who came up with flowable composites and taught them first is Terry Douglas from, I think, Alabama in the States. And he was talking about this for like 15 years now. He was teaching this technique by cutting vents with a burr. I find all the dust, the silicone dust that goes on the inside of the stent annoying, and I have to clean it and steam clean it. So I'm using actually the tips of the flowable, and I push them through the clear silicone, and I make a hole which is exactly the same diameter as the composite tips. The next thing to do is going to be surface treatment. You're not going to bond on a tooth that has a little bit of Turkish coffee on them or some breakfast. So you have to clean the surface. Air abrasion with alumina is by far the best. I will actually take a disc and I will bevel the surfaces to freshen up the enamel and get rid of any aprismatic enamel. I'm going to wrap around some Teflon tape for the alternate tooth technique. I don't want the teeth with the Teflon to get any edge or any bond. I just want the other two to be bonded. Those of you who are thinking, why is he not using rubber dam? I will tell you that rubber dam and injection molding are fighting against each other. They're not good friends. The stent has to sit down, not just on the teeth, but on buccal tissue and palatal tissue. And the rubber dam pushes it up. So I haven't had good experience for the injectable technique with a full rubber dam. A split dam, yes, but a full rubber dam, not sure. After particle abrasion, etch with phosphoric acid, total etch technique or whatever technique you use. You place your adhesive generously, cure it, and then insert the matrix and inject through that. You might be able to see that the excess of the composite is going sideways. Well, you expect that to happen. So when you remove the matrix, this is how it looks. So 2 incisors are done. The other 2 incisors have blankets, PTFE tapes, Teflon tape, and composite on top, but it's not bonded. The excess goes sideways. So I will take a knife, and number 12 blade is by far the best, and I will go up on the connector, and that will break off the unbonded composite. One has already come off on the left incisor, and I'm here removing the one on the right. Then I will take my strips, the metal strips. The Comet strips are by far the best. I don't know if it's the same product in Turkey, but they come in yellow, red, and blue coarseness. And I will use this S-shaped fashion to do the proximal reduction. I'm not going to just run it up and down. That doesn't give the correct shape. So it has to be sigmoid. 2 done, 2 to go. I put my Teflon tapes on the teeth that I have done, and I repeat the process for the other 2. The cleanup now is easier because the first 2 are done. But when you do the first set of alternate teeth, there is quite a bit of cleaning up. Glycerin will always be helpful to cure the composite fully because of the oxygen inhibited layer, and that is the final result. Let's watch another little video. This is my nurse. I was doing lots of cases and she says, okay, I will have that. She has a small lateral incisor with spaces between the central and the canine. So I just did additive bondings just on the central. So right at the end, I took out the retraction codes. I'm going to talk about the retraction codes. So that was just a single tooth, monochromatic. This was my nurse Alex before I added on small lateral incisors. If I closed up the spaces with orthodontics, she would still have small lateral incisors. So I just did that in monoshade. There's no opalescence, I know. It's a little bit monochromatic, and that's the lateral view, but it's a pretty good result for monochromatic. Now let's talk about sequencing, because I'm going to be creating some questions that I'm going to say, how does he do this? He does this and then that and that. It's a bit confusing. So I'm going to say it again. It needs hands-on training. Just 1 hour of Costa talking online is not enough. So let's talk about different sequences. You can do one tooth at a time, but it's very slow, like freehand. You have the ability to do alternate teeth or more teeth. What you don't have is the ability to do all the teeth together. So if you're doing 8 teeth and you're injecting on all of them, they're going to get stuck. And then it's going to take you forever to break contacts. Put the metal separators, and it's a disaster. So there is a technique in the UK called SmileFast, which is designed to do this with metal separators inside the stent. It makes it quicker. I'm not interested in quicker. I want to do it slow and I want to do it well. So one option is you inject on the alternate teeth and you allow the excess to overflow on the adjacent teeth. And then you have to clean up. So there is some cleaning up. Alternatively, another option is you do some stoppers. What do I mean? The right central incisor has been injected with the final composite. The left central and the lateral, they have a little bit of bisacryl. They are part of the mock-up. They're just sitting there and they're stopping the flowable composite from going sideways. It's a little trap. A retraction code will always help. Sorry, let me close the door. A retraction code will help because it will make a very clear margin between composite and tooth. So whenever I can, I always use retraction code. And I call this tenting. So it's like a tent. You take the Teflon tape and you can see 2 different things. On the distal, it's going over the papilla. On the mesial, it's not. Well, guess which one is better? Of course, the distal. So the retraction cord and the Teflon tape, they create a frame, an escape frame. The material cannot go any further out. It's trapped. That's why I prefer not using the rubber dam, because it's going to stop the silicone from sitting down. Another technique I'm working on now is to make 2 different stents. So let's say you're doing 6 teeth. You can remove the wax up on 2 of them or 3 of them, and you do the first 3 with their own stent. You finish them, and then you have a separate stent for 6. In this way, you don't have any cleaning up. The problem is that you need 2 different stents. And on the digital workflow, that is very easy to do. You press a button, and on whatever software you use, InLab or Dental Wings or any software, you kind of delete individual wax-ups, and then you only make a stent for 3 out of the 6 teeth. So it's a very good alternative technique. These are the essentials for finishing injectable composites. I have these a lot. Lots of number 12 blades. They need to be curved. Each blade is going to give me 2 or 3 teeth, and then I put it in the bin. I have to get another one. Just because it's very sharp, it doesn't mean it stays sharp. So I keep changing them. The metal strips that I talked about before, proximal reduction, or some metal separator to break contacts. But in the technique I'm describing, you're not going to stick teeth together because of the Teflon. So this is the anatomy that you can achieve with injectable composites. This is not natural teeth or veneers. This is injectable composites. Okay, here I have 2 stupid vertical lines. There must be scratches. I don't know how I did this. But the rest is beautiful anatomy from my lab. I do not need discs. I do not need burrs. That's why I use a wax-up. I don't have to create anatomy. I'm lazy. I want my lab to do this, not me. They're better than me. So maybe sometimes I will use a disc on the palatal side if there is a little bit of excess, like a step of composite, but on the facial, on the buccal, I don't want to use anything. But I still have to use my silicone points. I like the ones from Optident. Well, you probably have different names. They're similar to the spirals, like the EV polishers from Germany or the 3M polishers, followed by a gold hairbrush at 5,000 RPM, and maybe a little buff at the end with a polishing paste. So these are finishing. They're not these are polishing. They're not finishing. You still need them to get the high luster. Let me go through some cases. This is George. George is a very young guy. He had a lot of gastric problems and a lot of acid problems. He had short teeth, but not straight also. So his occlusion was a class 3 edge-to-edge, not easy to control guidance. So I sent him to an orthodontist to do some basic orthodontic treatment, bring in that canine which is sticking out, and give me a little bit more of an overbite and an overjet, just to put the teeth in a better position. So this is at the end of orthodontic treatment. We still have short teeth. They need to be added on. Erosion is a classic thing that can be treated with composite. Does it need ceramics? No. Can you put ceramics on erosion? Of course. But he doesn't have a single facet. He's not a Braxist. He's not parafunctioning. He has reflux, which is stable because I sent him to his doctor. So at rest, he's not showing any tooth. He looks like his grandpa. He looks 60. When he smiles, the smile is canted quite a lot. This is my smile design. This is my version of DSD. I don't need the full application. I just have my templates. It's an old-fashioned kind of design, two-dimensional, and I will draw these over the teeth, and then I will send this to my lab, and I tell them, this is where I want the teeth. That's how they're going to look good. Christian Coachman does it in a very delicate, beautiful way, but it's not the only way. My lab then did a digital additive wax-up. You can see the line of the original teeth, and you can see the proposed line. It was on all anterior teeth and all posterior teeth. I wanted to control the occlusion, so I added on the lower back teeth. Then they go ahead and print a model. And on that printed model, they can make the clear silicone stents. So there is one for the lower right, there is one for the lower left, and there is one for the lower incisors. These are the screenshots of the wax-up. I look at them and I approve them. A digital Facebook was done where it relates the teeth to the eyes using the in-lab software from Dentsply Sirona. This is George at the beginning. This is George on the mock-up. And that was a bisacral mock-up. The picture on the top is Luxatemp. The picture on the bottom is a printed PMMA mock-up that the lab sent me. So they overlapped the before model with a proposal, and the difference between the two was printed in resin. But that resin comes out very white, very wrong, and it looks rubbish. So it doesn't help the patient. So the bisacral is much, much better. I could spot a problem. You can also see it between the left canine and the left premolar. There is a step. So I decided to add on the premolars to get rid of that step. That is the power of the mock-up. So these are the intraoral views. When I do a mock-up, I don't just check aesthetics, I check occlusion, and I also check phonetics. So the incisal planes were correct based on what I wanted. When the patient occluded, the occlusion was good. On the left side, it wasn't, because the orthodontic work didn't go very well. So it wasn't very well controlled. So there was a bit of a space there. This is me starting doing the injectables. I just did one tooth. This was one of the cases I did at the beginning. So I was very slow. So I put my mock-up stop on the left and the right incisors, and that didn't let the flowable composite going sideways. So I've done one tooth, and then I'm moving on to the other ones. This is a few problems that the posterior has. At the back of the mouth, no matter how you do it, you need to have rubber dam. There's no way you can have good isolation without rubber dam. So maybe modified rubber dam, but at the back there's cheeks, saliva, tongue. You can't do adhesive dentistry. What I want to show in this picture is, can you see the lines on the mesiobuccal cusp? This is not the burr. This is the printer. This is the printer through the clear silicone, through the exoclear. So that high detail is transferred. You can also see, you can also see the injection vents. This is where I injected from, and then with a knife, I just chop that off. Here on the proximal surface, you're going to think this is a disaster. Well, the composite is not glued on the other tooth. So I can go with a blade and I can remove it and shape it. If the detail is very good on the wax up, this is just going to break off. So it's easier than you think it is. This is George with the initial, the mock-up, and the final. Some more close-up pictures. This is monoshade composite. There's no layering, it's just one color. And this is the tooth display at rest. That's how it should be for a 30-year-old. This is the occlusal view. And yes, I can maybe get this palatal anatomy freehand, but it's going to take me many, many hours. So I prefer to inject it and then go for a coffee instead. This is the lowers. Again, beautiful anatomy recreated without having to sculpt composite paste. This is George before, this is the proposal, and this is the final result on his upper anterior teeth. I think this was an A1 injectable case. Case number 2, diastemas, 19-year-old. She has big gaps. Look at the space between the left lateral incisor and the left canine. It's huge. You're thinking, there's no way I'm going to add composite or ceramic, it doesn't matter, that we need orthodontics. We need to close the spaces. Well, when I don't know what to do, I do a wax up. I draw my lines, and I know that the lateral incisor cannot take up the whole space. Otherwise, it's going to look like a fat central incisor. So I get this lateral to look like the normal proportions of a lateral, but the canine has to take a hit. He has to get fatter, and the central has to get fatter. Centrals are not very good at looking fat, but canines are fine because they're big teeth. They have the potential to look fat. This is my additive wax up. Different color than the model. Partial wax up on the centrals, partial wax up on the canines, full contour on the lateral incisors. And this is the mock-up. The mistake that I did here is I used A1, whereas that girl, she wanted the super, super bright, the turkey look. Sorry. But she wanted really bright teeth. it looked a bit yellow. The bottom picture, I have half the mock-up in and half the mock-up out. I find this picture very useful. I don't know why, maybe for my students, probably not for the patients, that half the mock-up is there and the other is not. And you can see the before and after inside the mouth. So she approved it. She said, that's fantastic. Yes, the canines, they look a little bit fat. I'm not going to say no, but she says, I don't care. This is good for me. I don't want braces. I don't want Invisalign. I'm okay like this. So we went ahead and we did the injectable composites at this design. So I did my tenting. I covered the papillae and I added on the central and the canine. This was just before COVID. This is on the day of me injecting. It doesn't look excellent. She never came back because of the lockdown, because of COVID. I hated the incisal embrasure between the two centrals, but she loved it. She didn't let me to fix it. She didn't let me to add material. And I said, please, let me add some material there, but she didn't let me. Anyway, so this was monoshade bleach composite. Yes, it's a little bit patchy, but when I saw her for a review, these were gone. Case number 3. This is a subtracted wax-up. It's the last case that I want to show you. We're going to see this more and more and more. As a prosthodontist, I have a lot of implant cases that were done in Brazil, in Greece, in whatever country, and they come to me, hey, my crown broke, fix it. And I haven't got a clue what was done. And I have to do the shopping and I have to find out what was done. So there's problems happen. Nothing lasts forever. Composites work on average about 3 to 5 years. And whoever says that they last 15 to 20 years, they just haven't done enough composites. So this lady had a makeover 5 years ago. Composite veneers. They get matte, they lose their shine, they pick up staining, what we call a halo, and they chip. That's what happened to composites. We all know that. We all know that. So she wanted them redone. Remove them and redo them. So that's what I did. But the two central incisors are quite, not Bugs Bunny, but they're a bit thick. Buccolingually, they're a bit too thick. So I wanted to bring them back. I wanted to give her a wider smile. So I cannot do a mock-up. Why is that? If you look at the occlusal view on the right, the pre-op on the top, the teeth are fatter than the one downstairs. So it's a subtractive wax-up. What the lab did is they removed some volume from the facial and they added wax, but they removed more than they added. So if I take a stent and I put it in the mouth, it's not going to sit. I have to cut the teeth first. But if I cut the teeth, that's not a mock-up. That's treatment. So I told the patient that, hey, you have to trust me. Why? Because, I don't know, trust me. I cannot show you how it's going to look. I can only show you on the model, not in your mouth. So I did my clear silicone stents. I made my vents, the holes through the clear silicone. This is the before. And here I have removed the composites on the left. And I found the reason why she had them done. The forensics, the CSI. So she had this fluorosis and a little bit of crowding. And you removed the composites on the other side. What did I use to help me? I used the light from GC, which has this function that shows you if there's any resin left behind. It's an amazing facility. Yes, you can get a little UV light from Amazon, or the Turkey version of Amazon, which is an ultraviolet light. and it will illuminate composites when you're removing your Invisalign buttons, for example. So I told her, I said, listen, Katie, shall we send you for some Icon treatment? Icon is a product from DMG, is resin infiltration, manage the contrast between white spot lesions and good tooth. So we do a bit of Invisalign, a bit of Icon, and some whitening, and you're done. She says, no, no, no, no, no. I did my composite veneers. I'm stuck now. I'm on the chair. Just do them. But I had to ask her because she didn't need composite veneers. There's modern ways to manage these problems. So I went along with new composites. Here I start injecting. I've done one tooth, just one tooth at a time. You can see that there is no opalescence. There is no halo. I don't get the incisal effects that some of you are getting with your ceramics or with your layered composites. There's no opal, there's no halo, it's monochromatic. Patients, they don't really want the incisal effects. They're not asking for them. So if you're doing one tooth, yes, you need the effects because you're matching to the others. But if you're doing multiple teeth, you get away with it. Nobody will notice. So it's a bit monochromatic. This is 2 teeth done and then 6 teeth done. So can I get this anatomy freehand with my manual skills? Yes. It will take me a lot of time, but on a Monday morning, I'm not going to be as good on a Wednesday afternoon. The injection molding technique gives you consistency. No matter how good you are doing, if your football team lost or if you had an argument with your wife, you're going to do the same level of work. So this is the final composites at the end. And you can see the baccolingual volume is improved. And it's like restorative orthodontics, what I have done, but without making the teeth fatter. This is Katie at the end. So you have all that surface texture that, yes, you can do with normal freehand anatomy. And there's excellent composite teachers in Turkey. But in this technique, the lab makes the anatomy. This is from another case where you have your primary anatomy, your lobes and your grooves and your perikymata incorporated into this anatomy. To finish off, this is just 2 pictures of a case I finished very recently, very severe erosive tooth wear. You're looking at this and you're thinking, where do I start? What do I do? Well, where am I going with this? But through the process of diagnosis, mock-up, and inject, I managed to do this. Could I do this freehand? No, I cannot. I cannot do that freehand. Maybe you can, but I can do it using the injectable technique. So my advice is to go ahead and do it. Don't start tomorrow morning doing it because you need a little bit of guidance from somebody who has done this technique. I'm not in Turkey. I'm sure some people are teaching this technique in Turkey. These are my details. Please contact me if you have any questions, and I'm happy to answer questions over Instagram or an email and share my experiences. I hope you found this useful, and Çok teşekkürler.
Thank you, Kostas. It was a really nice presentation, and I learned lots from your presentation because you did really difficult cases, especially the last one, are really difficult to practice in clinic in direct way. So you show us something nice from your clinic. So before we end today's webinar, we need to see the comments from the audience. Okay, there is a comment from a Turkish audience, a Turkish colleague. She's asking a question about the proximal, interproximal area. How do you manage this part of I think in the anterior area, how do you manage that? How do you prepare the interproximal area, the contacts of tooth, and maybe interproximal area with the gingival, how to say, with the gingival neighboring area in the deep part of the proximus?
It is the most difficult part of the injection molding technique. You're going to have some excess. That excess wants to go in the little black triangle between teeth. But because the clear silicone is going to go so much inside that proximal area, it's going to be so, the excess composite is going to be so thin that a blade, a knife, number 12, like a scaler, is good enough to get rid of it. It's not going to be a big lump of excess composite. So the detail of the wax up is reflecting on the detail of the stent, and that's on the detail of the composites. So yes, there is a bit of cleaning up, but you only need a 12 blade, nothing more. Maybe the proximal metal strips, but that's again the same for freehand composite. So if you have an excellent wax up and an excellent clear stent, I actually have one in front of me here, the detail proximally is very good, and all you need is a number 12 blade. My advice is that after you do this technique for 5 times, you work out all the possible mistakes that you can have, and on the 6th time you are good to go. You are like, you've done all the mistakes, so it's just the first 5 times.
Thank you. And I have a question.
Yep.
You mentioned in your presentation that the wax up of technician should end not should end away from the gingival margin.
Yes.
Otherwise, you will have difficulties about managing the resin margins. Is that right?
Correct. That has a little problem, because if you have a natural tooth, on the cervical area, it's going to look a bit yellow. Enamel is going to be worn away. So if you keep the wax 1 millimeter short, you think, ooh, I'm leaving a band of tooth, a halo of yellow tooth. But the chameleon effect of GC composite is so good, even if you work on a bleach shade, that this has never been a problem for me, having gum, tooth, and composite, this sandwich effect. The main problem is if the wax goes all the way to the end, then the excess is more. And I have to use a blade and maybe a disc, and then I cut the gums, and it's not great. So just because the GC materials have this beautiful chameleon effect, they take the color from the tooth, it's never an aesthetic problem. So I ask my labs to just stop about 0.5 millimeter or maybe 1 millimeter from the gingival margin. And that also helps with the emergence profile, because we all know things look wrong when the emergence is wrong. It doesn't matter if it's porcelain or composites. So the one area where you cannot add a lot is the cervical. Mid-tooth or incisally, you can add kilos and kilos of wax. But cervically, it's always going to look like chewing gum.
Have you ever had a chance to work with the large, medium diastemas? Injection molding. Have you ever tried injection molding technique on large, medium diastemas?
it's some colleagues of here in the UK, they were saying, no, you can't do injection molding for diastemas. It's an amazing case. For example, peg laterals, peg-shaped laterals, the little laterals, which is like a diastema case, like the one I showed you. So if you have a beautiful wax up with very good detail proximally, then you get that natural emergence. To do that freehand, it is possible with curved matrices, metal or plastic, but not the standard acetates or not the standard Teflon tape. So I have done several diastema cases. You do one tooth, you finish it like you're not doing anything more, finish it off, and then you move on to the next. Because the best opportunity to go proximally is when you can see from the side. So diastemas is a fantastic indication for injection molding. Yes, black triangles isn't. This is a bit of a problem.
And because it's difficult to get an access for the needle for the tip of the flowable compass. Is that right? You mean the black triangles is difficult to image because of you cannot reach that area.
Correct. You have to come from the facial.
Buckler.
And whenever you're making small additions, this injectable technique doesn't work. It likes having quite a bit of volume. So if you're adding tiny little corners on a lateral incisor or black triangles, you need freehand. Or like BioClear technique with their type of injection molding, which is very, very good for black triangles.
There is another question from a colleague. She's asking, besides these black triangles and these small edges, do you have any cases that got failed? Or what are the reasons? Could you please briefly discuss it, where you got the failure?
Yes.
And what would be the main reason for that?
Thank you for asking that. It's a very good question. It's a topic that I cover on my hands-on day with GC. I spend 1 hour on problems. So one problem with this technique is the excess. Okay, so it doesn't have a lot of excess, but you saw on the video when I was treating my nurse, you have cervically some excess. It's very easy to clean, but it's there. A second problem is that when I make the holes through the clear silicone and I inject through that, then I pull the syringe out. When you're pulling the syringe out, this can trap some air behind. So right on the incisal tip, where you don't want any bubbles, voids, you can have a little air trapped, and you're going to be able to see it. It's going to like talk to you. It's going to say, hello, I'm here. And then you have to expose it, you have to make it bigger, and then you have to inject again. So there is a little bit of possibility for, let me put it this way. When you're making temporary crowns with Luxatemp or ProTemp or whatever,
or
ProTemp or Integrity or whatever you guys use, you always have bubbles, always. It's like you just don't know that you have bubbles. So with the injection molding technique, I get some bubbles 1 in 5 cases. So I look for them, I inspect the teeth very carefully, and I put the curing light to see how dense the material is. And if I see a bubble, I will open it, I will expose it with a knife or a burr, and I will inject in it again, because I don't want to leave it behind. It will catch staining and food and blah, blah, blah. So this is the problem that I have found. The last thing that I have found has to do with chipping of some corners. So it's a composite material. I don't think it is specific to the technique of injection molding. We are using composite. We are using composite. So it is going to chip, because we're going to be optimistic, and we're going to say, yes, you grind your teeth, but I'll go for composites. You know that really you need ceramics, but you're giving it a chance. And the distals of the lateral incisors, they break, or the lower premolars. So what I tell people, my patients, is that there is a maintenance budget, that you have to pay me for doing them, but every year you're going to have to pay me that much money, I don't know, 500 Turkish lira, whatever, to refurbish them. It's not that I do them once and then you go away. You have to come back for polishing, for tidying up, because they're going to go a bit matte. They need polishing and maybe small additions. But I use the composite primer from GC and the same stent, and the repairs are very, very easy. I don't even have to do them freehand. So yes, thank you for the questions. There are some problems: excess, bubbles, and chippings.
Okay. So I think we have completed answering all those questions. So thanks for your nice lecture. It was really great to see cases and to hear your experiences. And looking forward to watching your webinar again, or meeting you soon, maybe in Turkey. And
great. Thank you for having me. And I'm very passionate about this subject. Do send me a message if you have any questions. I'm happy to answer them. Even if you do it in Turkish, it's okay. I will ask Arzu to translate. She's downstairs. So
maybe you understand some part of the. You'll understand the questions
I do, yes. I'm good in a restaurant. I'm good in a restaurant.
Okay.
I'm perfectly fluent. I have one FS, and then I speak like a professional. So thank you for having me, and iyi akşamlar.
İyi akşamlar. Okay, I will end this webinar right now, and so for the next part of this symposium, the last part will be in Turkish, and it will be about endodontics, and we will have Prof. Mehmet Bayburg Kayhan from Turkey. Evet arkadaşlar, bir sonraki sunumda eğer dinlemek isterseniz, izlemek isterseniz Profesör Doktor Mehmet Bayburg Kayhan'ı izleyebilirsiniz. Ben bu akşamki sunumu kapatıyorum.